February is Heart Month. To help us take a look at heart health, Dr. Aaron Kugelmass is Medical Director of the Baystate Heart and Vascular Program. Thanks for coming in, sir, taking time out of. Cardiologists always have very busy schedules, so we really appreciate you being here.
Especially when snow falls and there's lots of snow-induced
let's
disease.
Let's talk about that in a minute, but heart attacks, the time it takes to get a patient to treatment is critical both in terms of their immediate and long-term prognosis and survival.
Absolutely, and I think it is better understood now than it ever has been in the past. We talk about a golden hour in which the heart muscle is being deprived of oxygen, because that's really what a heart attack is. And during that time, the heart muscle is yet to die. So we've got about 60 to 90 minutes in which to get something done, the golden window. And if we can get that artery reopened and get blood supply back to the muscle, one, the acute prognosis, as you mentioned, the in-hospital prognosis is improved, but their long-term prognosis is improved because oftentimes that heart muscle will recover its function, and that makes a huge difference in the quality and the quantity of patients' lives after a heart attack. So I would say for the last, heart disease has been the #1 killer in the United States for a long, long time. The first major breakthrough probably occurred in the late 1980s with what was called reperfusion therapy with clot-dissolving medications. And at that time, the baseline prognosis of somebody having a heart attack was in-hospital mortality of at least 15%, maybe higher. And we're not talking about what happened after the hospitalization. By the 1990s, with the adoption of that reperfusion therapy, it was probably down around the 7.5% mark in the best case trials. Now it's in the 2 to 3% range. You come into the hospital. So what explains that difference? Yes, we do angioplasty very often as opposed to clot-dissolving medications, but that's not really it. What's really it is the adoption of systems of care that make sure that patients go directly to a site where they in fact can get these life-saving therapies and all the coordination that's involved with that. I started a program in Michigan prior to moving here that included southeastern Michigan and parts of southwestern Ontario, but it was all about that reperfusion therapy, whether it was with a clot-dissolving lytic agent or with primary angioplasty. When possible and readily available, primary angioplasty is probably a little bit better with some fewer risks than the clot-dissolving medication. But you cannot have an angioplasty suite that's manned 24/7 on every street corner in every community in America. So clot-dissolving medications, when given early in the right settings, can be equally effective as angioplasty, especially when those patients are then brought to a hospital where if the vessel decides to clot off again, we're able to open it in a very timely fashion.
Let's talk about that. You do have an angioplasty suite ready to go at Baystate Medical Center. And I know there's a fascinating phrase I ran across in the reading that you talk about the door to balloon time, the balloon angioplasty. You clear that. The critical, again, factor of time in getting the person, not just the hospital, but really right into the suite for treatment.
So the benchmark door to balloon time is in fact 90 minutes. Which sounds like a long time, and if you're having a heart attack, it's a very long time, but to try to assemble a team, it's not necessarily such a long time. So I would say the real breakthrough that's dropped the mortality rate has in fact been very directed approaches to setting up these what we call systems of care, where everything is fine-tuned, where processes occur in parallel rather than in series. So in our environment, and I was in fact on call last night, I was on the phone a couple of times. I, in fact, did not have to come in. Okay, if you were having a heart attack out at your home and you called 911, we were able to get an EKG even before the ambulance leaves your living room. That's then transmitted in. Our team is activated, and as you're driving in, we're driving in. Okay, the teams there oftentimes will beat patients to the door, apropos of the door, and then we proceed and do the opening of the artery with an angioplasty.
And even with a phone today, with a smartphone, you literally can be seeing what's happening with that patient as they're still coming to you.
We certainly can get interpretations. There are some HIPAA or Health Information Privacy Act issues around transmitting data over smartphones, but we're getting past that with encryption technology. But to your point, yes, I can actually get an EKG by somebody taking a picture with their iPhone and texting it to me. But the bigger issue is the emergency room is getting that information fed to it live, either via wired or wireless technology. And so they're anticipating the heart attack victim coming in. We're coming in. We're teed up. We often know what artery is most likely involved before the patient ever reaches the door. It's very different than what it was 10 years ago, where you would make your way to the hospital. It might take a while to get an EKG, it might not. Might take a good long while, 90 minutes or more, to in fact make a diagnosis. And once you've made the diagnosis, then we have to assemble the team, and that can take an awful long time too. So this has been very, very streamlined. Mm-hmm. And this is one of these things where you get a couple of gray hairs at least. You get to see a real evolution in approach, and this is night and day compared to what it was before. 2000, 2003, less than half of the patients in America who were eligible for this reperfusion therapy, either with angioplasty or with the clot-dissolving medicines, got it. Now it's in excess of 80%.
Well, let's talk about, you mentioned this, and not to take it too far, but this is heart attack weather, if you will. Not only the shoveling of the snow, and so much of the snow, so you're shoveling longer period of time, and also just the cold air is very tough on the whole system. This is time for people to keep that in mind.
This is very much time for people to keep that in mind. It has been documented in the medical literature that snowstorms are associated with an increase in heart attacks, okay? Now, the snow we've had lately has been fairly light, okay? But if one is to shovel a driveway, particularly with wet, heavy snow, you're lifting tens of thousands of pounds. It's sort of like unloading a tractor trailer manually. And for somebody who doesn't do that every day, that puts a lot of strain on the system. At the same time, when it's cold outside, the arteries naturally vasoconstrict or tighten up. And that combination of all that work with the vasoconstriction is a real setup for a clot to form in a site of plaque rupture where the cholesterol plaque in fact is. So this is real. And as I was rounding in the CCU this morning, there were at least 3 or 4 snow-associated heart attacks that had come in over the course of the weekend.
Let's talk beyond that briefly. Lifestyle in this country today. What we eat, how much we eat, because we do have an abundance. That too is a big part of seeing all the patients you see.
Lifestyle is certainly a big part of this. If one likes to think about this, this is a disease of inflammation or irritation of the blood vessel. It is a disease that occurs because of the success of modern medicine. We live into our middle and older age, and this is something that occurs with aging. It starts early in life, but it occurs with aging. Certainly certain fatty foods. A lot of debate in the literature of late as to which fats, but perhaps more processed fatty foods. In many ways, things that we thought were better than butter long ago maybe are not so much better. But a lot of it, I think, when you get to the key issue is moderation versus lack of moderation. And the American diet and the American waistline just keep getting bigger and bigger. And it's an issue of abundance. Food was scarce for the majority of human history, and it's now having smaller portions is actually more of a challenge than having larger portions.
Wise words and good advice. Dr. Aaron Kugelmass, Medical Director of the Baystate Heart and Vascular Program. Thanks for being with us, sir.
Thank you so much for having us here, and thanks for recognizing Heart Month.